Hey everyone, so today we are going to continue our section of cardiology, and today we are going to study cardiovascular pharmacology. So we have the hypertension treatment, primary essential hypertension. So it is basically the hypertension that is idiopathic in nature. The drugs used to treat primary essential hypertension are thiazide diuretics, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. Then we have the hypertension with heart failure. So we have studied the heart failure and hypertension with heart failure. The drugs that are used to treat include diuretics, ACE inhibitors, beta blockers, and aldosterone antagonists. So beta blockers must be used cautiously in decompensated heart failure, and they are especially contraindicated in cardiogenic shock because the heart already has lost its ability to pump enough blood, and by slowing the heart rate, we are compromising its function. Then there is hypertension with diabetes mellitus. So ACE inhibitors or angiotensin receptor blockers are considered a drug of choice in hypertension with diabetes mellitus. However, calcium channel blockers, beta blockers, and thiazide diuretics are also used. For asthma, beta blockers are especially contraindicated because they are known to cause vasoconstriction in the lungs. Therefore, angiotensin receptor blockers, calcium channel blockers, and cardioselective beta blockers can be used. For hypertension in pregnancy, there are only four drugs that are useful: the nifedipine from calcium channel blocker, methyl-dopa, which is an alpha blocker, labetalol, which is a mixed alpha-beta blocker, and hydralazine, which is again an alpha blocker. So the calcium channel blockers include amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, diltiazem, and vitapimil. We broadly divide calcium channel blockers into two types, that is the dihydropyridines and non-dihydropyridines. So the dihydropyridines act on vascular system, and the non-dihydropyridines are the cardioselective. Mechanism of action depends upon the blockage of the voltage-dependent L-type calcium channels of cardiac and smooth muscles, thereby decreasing the contractility of the heart tissues and the muscle tissues. In vascular smooth muscles, amlodipine and nifedipine has the equal efficacy. However, both of their efficacies are greater than diltiazem or verapamil that are cardioselective, and in heart, verapamil and diltiazem has greater efficacy than amlodipine or nifedipine. The clinical use of calcium channel blockers is indicated in hypertension, angina, nimodipine, which is the drug of choice for subarachnoid hemorrhage. And then you have the nicardipine and clevidipine that are used in hypertensive urgency or emergency, and non-dihydropyridines that are cardioselective can be used in atrial fibrillation, atrial flutter, hypertension, and angina. The adverse effect of calcium channel blockers include gingival hyperplasia, peripheral edema, flushing, dizziness, cardiac depression, and hyperprolactinemia, which is specific to the verapamil. Hydralazine acts by increasing the cyclic guanosine monophosphate pathway, which results in smooth muscle relaxation. So it basically vasodilates the arterioles, and there is decreased in afterload or systemic vascular resistance. Its clinical use is in severe hypertension, particularly acute hypertension, heart failure, and it is also safe to use during pregnancy. The adverse effect includes compensatory tachycardia, fluid retention, headache, angina, and drug-induced lupus. Then, then we have drugs for hypertensive emergency. They can be treated with labetalol, clevidipine, phenoldopam, nicardipine, or nitropiroside. So nitropiroside is the short-acting vasodilators which dilates arterioles as well as venules. So it also acts by increasing the cyclic guanosine monophosphate via direct release of nitrous oxide. It can also cause cyanide toxicity. The phenol is basically a dopamine receptor agonist that acts on coronary, peripheral, renal, and splanchnic vasodilation. It reduces the PP and increases the natriuresis. It is also used postoperatively as an antihypertensive. The side effects include hypotension, tachycardia, flushing, headache, and nausea. So the nitrates include nitroglycerin and isosorbide dinitrate or isosorbide mononitrate. The mechanism of action is vasodilation by increasing the smooth muscle vascular contraction through increased production of nitrous oxide. It also increases the CGMP pathway and causes smooth muscle relaxation. However, it acts on the veins more as compared to arteries. Its clinical use is for angina and acute coronary syndrome and pulmonary edema. So the adverse effects include reflex tachycardia that can be treated with blockers, hypotension, flushing, headache. Here these two minor drugs, ranolazine and scubatril. So the ranolazine mechanism is by inhibition of late phase of inward sodium current, thereby reducing the diastolic wall tension and oxygen consumption. It can be used in refractory angina. Adverse effects include constipation, dizziness, headache, and nausea. Scubatril is a naphthalene inhibitor that prevents degradation of bradykinin, and it is basically a natriuretic peptide. It increases the concentration of substance P, which causes vasodilation and decreases the ECF volume. Its clinical use in combination with valsartan to treat the heart failure with reduced ejection fraction. Adverse effects include hypotension, hyperkalemia, cough, dizziness. It is contraindicated with S inhibitors due to angioedema, which is a common side effect to both. Then there is an important drug that is the cardiac glycosides, which include digoxin. Digoxin is a direct inhibitor of sodium potassium ATPase pump, and it causes indirect inhibition of sodium calcium exchanger. So there is increased calcium in turn, which causes positive ionotropy, and it stimulates the vagus nerve to decrease the heart rate. So its clinical use is in heart failure with increased contractility and AFib by reducing the conduction at AV node and depression of the SL node. Adverse effects includes cholinergic effects such as nausea, vomiting, diarrhea, blurry or yellow vision, arrhythmias, and AV flow. It can also cause hyperkalemia, which indicates poor prognosis. The factors predisposing to its toxicity include renal failure because there is decreased excretion of the drug, hypokalemia, and drugs that displace digoxin from tissue binding sites. The antidote to digoxin or cardiac glycosides include anti-digox fab fragments. However, magnesium and slowly normalizing calcium and potassium has also been shown to be effective. Antiarrhythmic drugs are divided into four classes: the class 1, 2, 3, and 4. The class 1 is further divided into three classes, that is class 1A, class 1B, and class 1C. The class 1 includes quinidine, procainamide, and disopyramide. Their mechanism of action is moderate sodium channel blockade, which increases the duration of AP phase. It increases the effective refractory period in ventricular action potential and increases acuity interval. So therefore, it is used for atrial and ventricular arrhythmias, especially reentrant and ectopic supraventricular tachycardia and ventricular tachycardia. Its adverse effects include synchronism, which is headache, tinnitus, and irreversible SLE-like syndrome. Heart failure, thrombocytopenia, torsades de pointes are other well-known risk factors of class 1A drugs. The class 1B includes lidocaine, phenytoin, and mexiletine. So their mechanism is by weak sodium channel blockade. It decreases the appetization, but preferentially affect the ischemic or depolarized Purkinje and ventricular tissue. Its clinical use is for acute ventricular arrhythmias, especially post-myocardial infarction. Its adverse effects include CNS stimulation or depression and cardiovascular depression. The class 1C drugs include flecainide and propanophone. Their mechanism is by strong sodium channel blockade. They significantly prolong the ERP in AV node and accessory bypass tracts. No effect on ERP in Purkinje and ventricular tissue. They have minimal effect on the duration of action potential. Clinical use includes ventricular tachycardia, including atrial fibrillation only as a last resort in refractory ventricular tachycardia. Adverse effects are post-arrhythmic and especially post-MI. It is contraindicated. Then class 2 antiarrhythmics that are also known as beta blockers. So these drugs contain LOL, LOL at their suffix. Mechanism of action is by decreasing the SA and AV nodal activity by decreasing the CAMP pathway and decreasing calcium currents. AV node differentially is sensitive to beta blockers. There is increased PR interval. Clinical use includes ventricular tachycardia and atrial flutter and atrial hyperventilation. Adverse effects include impotence, exacerbation of COPD and asthma, and cardiovascular effects such as bradycardia, AV block, and heart failure. Other less known side effects are dyslipidemia and exacerbation of vasospasm in vasospastic angina. So the labetalol and carvedilol are non-selective alpha-beta antagonists. Then you have the class 3 antiarrhythmics that include amiodarone, eptilide, doftilide, and sotalol. Their mechanism is by increasing the AP duration and increasing the ERP and increasing the QT interval. Their clinical use is atrial fibrillation, atrial flutter, and ventricular tachycardia. The adverse effects are specific drug-wise, such as sotalol causes tosadase defantis, eptilide can also causes tosadase defantis. Amiodarone is a well-known drug which causes a wide array of symptoms such as pulmonary fibrosis, hepatotoxicity, hypothyroidism, hyperthyroidism, blue-gray skin deposits, neurologic defects, constipation, and cardiovascular effects. Remember to check PFTs, LFTs, and thyroid function test when using amiodarone. Amiodarone is also a lipophilic drug and class 1, 2, 3, and 4 effects as well. Then the class 4 antiarrhythmics includes diltiazem and verapamil. Their mechanism is by decreasing the conduction velocity and increasing the end respiratory potential. They also increase the PR interval. Their clinical use is in prevention of nodal arrhythmias such as SVT and that control in AFib. Adverse effects include constipation, flushing, edema, cardiovascular effects. Other lesser known antiarrhythmics include adenosine, which is a drug of choice for SVT. It increases the potassium out of the cells, therefore hyperpolarizing the cell and decreasing the calcium current. Magnesium is effective in tosadase defantis and ditch toxicity. Avopiridine is prolongs slow depolarization by selectively inhibiting the funny sodium channels. Their clinical use is in chronic stable angina in patients who cannot take beta blockers. Adverse effects include visual tightness, luminous phenomena, hypertension, and bradycardia.